Hello, everybody. My name is Paula Simaro. I'm an occupational therapist from Buenos Aires, Argentina, and I would like to share with you my experience with the use of the CMMS technique for the treatment of thumb EP joint stiffness. First of all, I would like to thank Robyn for this opportunity to continue growing and learning. I'm gonna introduce you my presentation. I am going to talk a little bit about my daily practice. Then we are going to refresh some key concepts. And then we are going to move on to the cases presentations. And we will finish with some conclusions. As I told you before, I live in Buenos Aires, Argentina. I work for the Italian hospital here in Buenos Aires. We are 14 occupational therapists in the OT department, but just 6 of us work as hand therapists. I also have my private office, and here is the place where I spend most of my days. Well, just as a refreshment, we know that the term stiff refers to a reduction in the range of motion that could be due to an intrinsic cause related to the joint or an extrinsic cause related to the tissue layers that are adjacent to the joint that has or may have a deficit in the gliding between tissue layers. And this is the question that I asked myself when I started to apply the technique and after taking the course. At that moment, I got some patients that evolved with flexion and extension deficit at the EP joint. And I didn't find any contraindication to apply the principles of the technique to those kind of patients. So I started to adapt the technique guidelines to the treatment of those cases. And today I'm going to present 3 of the patients that I've been treating. The first case was the first patient that I treated with this technique, and it was a female that received a primary tenography, and she evolved with a flexor tendon adherence and joint stiffness. The second case was a patient that received a tendon transfer after a FPL laceration, and he evolved with a flexor tendon adherence. And the last one was a patient that received a hallux transfer to thumb after a traumatic amputation, and he evolved with both flexor and extensor tendons adherence and joint stiffness. Those are the guidelines that I follow for the treatment of those patients. Not all of them follow each step, but all of them use the first cast in that position. Not all of them use the second one, and all of them went through a weaning period. The first cast position consists in 20 degrees of wrist extension, 45 degrees of palmar abduction, and the position of the MP joint depends on the degree of the deficit. I mean, if the patient had a flexion deficit greater than extension deficit, I position the MP joint in slight flexion so as to allow and facilitate the flexor's gliding, and to avoid the action of the flexor's pollicis brevis. And if the patient presents an extension deficit that was greater than the flexion deficit at the EP joint, I position the MP joint in greater flexion so as to facilitate and give the extensor tendon a mechanical advantage. And of course, all of them, in all of them, the EP joint was left free. In those cases that use a second cast, the position consisted in 20 degrees of wrist extension, 45 degrees of palmar abduction, and both the MP and EP joint were left free. For the winning period, we didn't use a bivalve cast in those three patients. We used forced transmission and mobilization orthosis because the three of them were tired and used the cast a long time. We are in summer, and well, they rejected to use a bivalve cast, and we took that other option. And well, for the first patient, that was the one that discharged therapy, we gave her a home routine to continue exercising and strengthening and dexterity, to continue exercising for reach more strength and dexterity, sorry. And the other two patients, the last two patients, will continue virtual therapy, so they didn't discharge therapy yet. Well, I'm going to move on to the first case. This one was a 36 years old female. She's a psychologist and a non-smoker patient. And as I told you, she suffered an FPL at zone 2 laceration from his left non-dominant thumb. And she also suffered an ulnar collateral digital nerve laceration. The accident was with a knife when she was cooking. So she received a primary tenorrhaphy and neurorrhaphy. Despite she initiated therapy 6 days post-surgery, and we go on through an early active motion protocol, she was a bit fearful, and she evolved with edema persistence, limited motion, tendon gliding deficit, and of course lack of functionality. Here you can appreciate the mobility she presented at 2 months and a half post-surgery. You can appreciate the motion deficit and the flexion contracture at the EP joint. Well, at that point, her surgeon thought that perhaps she was a candidate for a tenolysis in the near future, and we decided to try to avoid the surgery. So we treated her with the CMMS technique, and this was the first cast we applied. She used it for 2 weeks, and after 2 weeks, we changed the cast, and she moved on to the second cast, where we left the MP joint free. Here you can see her movement. And I don't have the pictures, but for the winning phase that started 1 month after casting, we decided to add, to take off the cast, and we add an extension EP joint mobilization orthosis to be worn during the night, and a forced transmission orthosis to be worn intermittently, because she needed to return to her job, and she wasn't allowed to return if she was using a cast. So we applied that forced transmission orthosis to continue exercising in between her daily activities. Well, so here are the final outcome at follow-up at 6 months post-surgery. We can appreciate an edema reduction, an improvement in flexor tendon gliding, and of course in the thumb formula. And she also presented an improvement in the motor cortex repatterning, and of course in functionality. And fortunately, surgery wasn't necessary. Here are the the results. She reached an excellent outcome at the background formula. She got a 9 in points at the Kapanchi score. The fist and pinch strength was similar to the contralateral side. She didn't refer pain, and she got a 0 point at the quick dash. And we have to realize that before casting, the quick dash got a 52.6. And well, she refers to be very satisfied with treatment. Well, so this was the first case. I'm going to move on to the second one. The second one was a male. He is a 60 years old technician and non-smoker patient. And he also suffered a laceration of his FPL at zone 2 from his right dominant thumb. And he received previous surgeries that were not effective. The first one was a primary sonography that was done in, he's from a city from the south part of Argentina. And there was the first surgery. And then he came to Buenos Aires where he consulted to another physician who performed a second surgery where he transferred the FDP tendon from his right finger to the FPL tendon. After I received this patient after the second surgery, 15 days after the second surgery, and he came to my private office without any standardized protocol and any proper immobilization guidelines. In fact, he came without any cast, without any immobilization. And at that point, and that moment, I tried to contact his physician because it wasn't one of the physicians that I used to work with. And so I didn't knew his doctor. So I tried to contact him and to notice him about that situation because when I started to assess the patient, I found that the transfer was not active. I mean, I think it was a rupture. So I advised the patient to go again to the doctor, and the doctor decided to do a revision surgery. At that point, he found that as I thought that there was a re-rupture. So he did a third intervention where he transferred the FDP tendon from his middle finger to the FPL tendon. So the patient contacted me again. So he restarted therapy 3 weeks after the third surgery. At that point, I appreciate that there was an edema and there was a limited range of motion. There was a tendon gliding deficit. There was scar addition. We have to take into account that these patients received 3 surgeries in a period of, I think, like 3 months. And well, of course, we start working, and this was the mobility, the passive motion. He reached 6 weeks after the third surgery. I think it was acceptable, but the problem was when we wanted to activate the transfer, we found that it was really hard for the patients to make that tendon to glide, and we used different resources to improve it, but it wasn't enough. So this patient was living at that moment he moved to Buenos Aires for his rehabilitation, but he was having economical problems, and he asked me to return to his city. But I proposed him to change our approach and to move to the CMMS technique application. So at that moment, I was going on holidays, so I applied him a cast, and I asked him to came to my office when I returned from my holidays. So we applied the cast, and when I returned from my holidays, I found that there was a huge improvement in the tendon gliding. He could start activating his transfer, and you can see that I blocked the MCP joint in this case because I wanted to facilitate the flexor tendons to glide. In fact, the FDP tendon from the middle finger to be activated so as we can transfer that activation to the recipient muscle that was the FPL. So after 3 weeks of cast use, I found the patient with this evolution, and at that point he asked me again to left him free to return to his city, but I proposed him to stay here some more weeks so as we can incorporate and to translate that motion to the functionality. And I explained him that if we leave everything like this, like that, perhaps he will went back. So we decided to take off the cast and to incorporate for the winning phase and forced transmission orthosis, as you can see here in the video. We return to traditional therapy, and we continue exercising through functional strengthening and dexterity exercises, as you can appreciate in those videos. Well, and this was the last video I could record before he went back to his city at 3 months post surgery. We accord that he will continue therapy through virtual sessions, despite he continue compensating through MP and CMC movements when he wants to grasp some object or when he wants to incorporate his finger to function. I think there was a really high improvement in flexor tendon gliding and of course in functionality. And this patient also his doctor considered that surgery wasn't necessary for this patient. Well, and the last case is a 30 years old male. He's a farmer and a non-smoker patient who suffered a traumatic amputation of the distal phalanx of his right dominant hand thumb, and he received a hallux transfer to thumb. He's also a patient that lives in a city from the interior parts of Argentina, and he came to Buenos Aires to ask for a reconstruction surgery. So he initiated therapy 6 weeks after being immobilized, and after receiving 6 weeks of traditional therapy, he evolved with edema persistence, he evolved with limited motion, with tendon gliding deficit, with passive motion deficit, with scar addition, and a lack of functionality that could be appreciated in the quick dash score, where he got a 17.5. Here is the X-ray that was taken at 3 months post-op. You can appreciate the surgical procedure. And that's the mobility he presented at that point. Here we can see that most of his movement is done through the CMC and yes, mostly from the CMC joint. And there was a lack of passive motion. he also had a little contracture at the first web space. So that was the first cast. And after 6 weeks of cast use, I found that the FPL tendon started to glide. Of course, he needs to continue training and exercising. He also asked me to return to his city. He needs to return to his job. So we accord that we will also continue through virtual therapies, sorry. And here is the mobility that he reached at 6 weeks after cast use. As I mentioned before, of course, this is a patient that needs to continue working. You can see that in the contralateral hand, he also has a flexion deficit at the MP joint. I mean, that's his normal range of movement. So for the weaning phase, we add a force transmission orthosis to be worn during the day, and he can remove it for personal hygienic activities. And we also add, here you can see how he moves the AP joint through the orthosis. And we also add a mobilization orthosis to be worn during the night for a first wave opening, first space opening, and also to work to treat the flexion contracture of the EP joint. Well, I think that here are the results at a follow-up at 4.5 months post-surgery. We realized that he still needs to improve in what relates to range of motion and tendon gliding. But I think the main improvement could be appreciated at the quick dash score, where he refers a 0 point, and in contrast to the outcome reached at before casting, that was 17.5. So we can appreciate a huge decrease in the outcome. And he also reached a good outcome at the Ramco score, and he referred no pain. Well, this is also a patient that I'm going to continue treat through virtual therapy, and he will come here to my office perhaps monthly to do a control and a supervision of his evolution. Well, just to summarize and to conclude, I would like to refresh the benefits of incorporating the CMMS technique on thumb injuries. I think that as in long fingers, it helps us to decrease edema, to improve range of motion, tendon gliding, and also to improve movement patterns of movement and cortical reorganization. It also helps us to improve, to treat strength, dexterity, and coordination. And last but not least, to reduce therapy and recovery times. So, and that was a really important key point for the treatment of those kind of patients that I present to you today. So thank you everybody for your attention, and here is my email in case you want to ask me something. Nice to meet you. Bye bye.